Thank you for joining the National Headache Foundation's webinar on tension headache. In today's session, we will be joined by Dr. Robert Kaniecki, Director of the Headache Center at the University of Pittsburgh. Dr. Kaniecki?
Well, thank you, and welcome to everyone here online this evening. We're going to review a few items regarding the topic of tension-type headache, and from there then open it up to questions about this topic that involves the most common headache in the population at large. So why don't we go ahead and get started? Next slide. So tension-type headache, to some degree, is a bit of a misnomer. I think people typically assign the term tension to stress, and that what we mean by tension-type headache is indeed stress headache. Well, stress is a very common trigger for headache, but lots of people are under stress, and many don't develop headache from that. So really what we're talking about is the biology of headache that involves certain characteristics. So migraine has certain qualities or features, cluster headache has certain qualities or features that would then be likely to be seen in patients who have these conditions. So tension-type headache is the same way. It's defined by the features of the headache. So the trigger, no. There are multiple triggers for tension-type headache. Stress is only one of them. And we will then look at then the criteria. So it's a matter of pattern recognition. So the pain typically is both sides of the head or all over, and not unusual for people to describe a band. The second feature on their pain quality side is the steady or non-pulsating quality to it. So it tends to be vice-like or steady as opposed to migraine, which is more likely to be throbbing. The pain is unaffected by movement, and typically patients will say exercise not only is not troublesome for them, but in fact often helps the headache. And finally, the pain of tension-type headache is characterized as mild to moderate in intensity for the majority of the attacks. It's actually rare for tension-type headache to have crippling degrees of pain. And with that, you have neither nausea nor vomiting, and you can have light or noise sensitivities, but you can't have them both. That's photophobia or phonophobia. So sensitivities to light and noise, one or the other may be present, and it's typically more common to see the sensitivity to light. So tension-type headache, in essence, actually is defined as the absence of features of migraine. Because as we look at the pain qualities, the migraine, if you would go down the same list on the left-hand side, migraine would be almost the opposite. Migraine is unilateral or one-sided more often. It is pulsatile or pulsating more often. It is affected by movement. It gets worse with physical activity and tends to be moderate to severe. So you can see what we're looking for here in tension-type headache are qualities that say, you know what, there really is no evidence that migraine is present. And that's going to be important as we kind of continue the discussion. Next slide. Once we define tension-type headache and the presence of it, that's it, right? And we have then two subcategories. Episodic and chronic are defined by the number of days of headache one experiences. So you can see if you experience headache more often than not, so if you have more headache days than headache-free days over the course of a year, you're going to be called chronic. If you are experiencing headache fewer than 15 days a month or fewer than 180 days a year, you'll be defined as episodic. So the majority of patients will fall into the episodic category. Episodic tension-type headache is the most common headache in the general population at large. So these are patients who are experiencing, or non-patients, just individuals in the population who are experiencing headache of the nature as we described with a frequency that is relatively lower. Chronic tension-type headache, on the other hand, is over 180 days a month or more headache days than headache-free days. And most of you may be more familiar with the term chronic as it's applied to migraine, where now advertisements on television for chronic migraine will define that as having migraine headaches more often than not, more than 15 days in a month. Next slide. So the features of tension-type headache in terms of the population prevalence, the frequency in the population, you can see it's the most prevalent, the most common headache in all age groups. It's the most common headache in all populations, all races, all countries where this has been studied. And it has the highest socioeconomic cost of all headaches. And that derives from the fact that it's just so prevalent. It's so common. So if you count up the number of dollars this costs the American industry of lost work days, although migraine is more disabling by nature, and a bad migraine day perhaps is worse than a bad tension-type headache day, there are so many more workers having so many more tension-type headaches overall that the numbers will then favor this condition as involving the highest socioeconomic costs. So the biggest impact, even though this might not be the biggest player in terms of severity in headache, because of its frequency in the population, it brings big numbers to employers and employees and families alike. So next slide. As mentioned, various countries will show the same statistic that this is the most common headache in the population. So episodic tension-type headache in the United States, you can see there in the third line, the biggest study that was done in 1998 established that 40% of the population in any given year, this is an annual prevalence, so over the course of a year, 40% of the population will experience tension-type headache that's significant enough to treat. And you can see that number is pretty stable when looking at the German statistics. The Denmark statistics, the Danish, have a higher number, and this perhaps has to do with the fact that the Danes have looked at tension-type headache a bit differently and tend to include patients perhaps that also suffer from migraine, where we in the United States often look at patients who have migraine and also have tension-type headaches. We tend to label them as migraine sufferers who also have some other smaller headaches, maybe smaller migraines. In Denmark, if you happen to have migraine and tension-type headache, they give you both diagnoses, both labels, and therefore the numbers are a little bit higher. But chronic tension-type headache, again, more than 15 days a month or more than 180 days out of the year, is 2.2 to 3% of the population at large. So this is a significant fraction. You're talking about numbers that perhaps are not as high as diabetes or asthma, where you're looking at 6%, 7% maybe of the population. But this is more than rheumatoid arthritis, for example. So very frequent tension-type headache, which is a significant problem for us in terms of management. It's a tough headache to treat. That is pretty common, as you can see there, somewhere between 2 to 3% of the population. Next slide. Non-drug management involves a number of opportunities. So like any other headache disorder, we would like to experience benefit from non-drug approaches if possible. So we want to certainly identify and certainly eradicate or eliminate any trigger factors. So should stress be a trigger, again, the number one trigger, then we would say, all right, let's see what we can do about stress management. Should, for example, sleep deprivation or sleep irregularities be a significant trigger for someone who has shift work? So we would look at trying to regulate them on regular days or regular evening shifts and avoid swing shifts. So identifying and eliminating trigger factors, very, very important for all headache disorders. What brings them on? Now, there are certain things you can't do anything about, weather being one of them, right? So if weather happens to be a factor in your headache, unless you have the opportunity to move, and sometimes that doesn't even work, there are some triggers you can't do much about. If someone says that their in-laws trigger their migraines, I'm not sure that we can really do much about that, but to try to minimize the contact with the in-laws. EMG biofeedback, biofeedback techniques of various types can be helpful. The EMG, or this is a machine-based biofeedback where needles are inserted into the muscles, and the feedback is muscle relaxation. So what we like to see, the tension name actually comes from not stress, as I mentioned earlier in the presentation, but from muscle tension that is very commonly seen in patients with this disorder. So the tension is more of a muscle tension emphasis, and that's where the name is probably more appropriately assigned. So EMG is electromyography, and that is myography is muscle. So these are needles inserted into the muscles, and then patients will, in a sense, almost looking like acupuncture needles, but they're hooked up to a machine that sends recordings and audio information that can then provide the patient with feedback. So when the patient relaxes the muscle, the sound goes down. When the patient is more tense and the muscles are more tight, the sound goes up. So they learn to relax, And the feedback loop is they're trained to do this by turning down the noise from the muscles of their head or neck or shoulders. What may be effective also are relaxation techniques or cognitive behavioral therapy, so a lot of that has to do with stress management. And what possibly is helpful, the data is not convincing one way or the other, physical therapy or acupuncture. So right now we don't know for certain whether physical therapy, osteopathic manipulation, chiropractic manipulation, acupuncture, there's not enough information to either support or refute their use in this headache condition. Now I show you the European guidelines because the United States still has yet to publish a set of guidelines. Our organizations here have been busy publishing guidelines on migraine, and hopefully soon we'll see the TensionType Headache guidelines rolled out. Next slide. We'll continue the European guidelines on what to do when you get a headache, when you get a TensionType headache. So the recommendations are to use simple analgesics. So many of these are over the counter, but basically simple analgesics such as acetaminophen and aspirin, and then non-steroidal anti-inflammatory agents like ibuprofen or naproxen or ketoprofen. All of these have been proven to be effective. Should you fail those types of agents if they don't seem to help, and then we're talking about decent doses. Usually when you're talking about ibuprofen, you're talking a minimum of 400 and typically between 400 and 800 milligrams. Or with naproxen, you're talking about doses in the 400 to 500 milligram range. The combination analgesics, if you fail the simple ones, then it's recommended to try ones that perhaps contain caffeine. And this is where the combinations that involve aspirin and acetaminophen and caffeine, they go by a variety of different names. Those combination agents are ones that can be very, very helpful. So they're considered to be options if you don't seem to respond to the single type agents. Finally, it's recommended that you stay away from narcotics or opioids, that triptans have not shown enough benefit to warrant perhaps their use in this setting, and to avoid muscle relaxants, despite the fact that muscle tightness or tension is a feature in many patients with this disorder. The typical muscle relaxants don't seem to do much good, so it's recommended to avoid those types of agents. So one of the reasons we don't see a lot of times TensionType headaches in our headache clinics is that most of the effective medications for the headaches are available over the counter. Patients can manage themselves, and it's not until the headaches become very, very frequent or when these medicines don't work that patients come to see us. Next slide. Preventive therapy is instituted when we see patients who are averaging more than perhaps 10, 12 days a month of headache. And the reason for that is many of you online are probably familiar with the term the rebound headache, or what we now refer to as medication overuse headache. It's much more common to see in migraine, but it also is possible in TensionType headache. And this is a situation where the headache is perpetuated, is worsened by overtreatment, that too much of a good thing becomes a bad thing. And we use the analogy in our clinic of over-fertilizing the plants, that at a certain point there's a tipping point perhaps where the fertilizer becomes not helpful but actually injurious to the plants. It starts to burn out your grass once you start, if you applied it, for example, every day. So the same thing here. Headache is not meant to be treated every day with pain relievers, in that not only do you get other problems when you take pain relievers constantly. If you take aspirin products or non-steroidal products, you can run into gastrointestinal problems, ulcers, bleeding problems, kidney disease. If you take acetaminophen frequently, more commonly the issue would be liver disease. So there are complications with overusing these agents, but what we're as concerned about is the fact that they feed the headaches, and that you go from 2 headaches a week to 3 to 4, and eventually you're stuck at a daily headache pattern and you're using multiple medications every day. So we'd like to restrict patients to 10 days a month or fewer of the use of any kind of pain reliever. And that's in combination. So it's not 10 days of acetaminophen and 10 days of aspirin and 10 days of naproxen each month. It's 10 days total, and we'd like to keep them there. And if they're not able to stay there, then we think about preventive medications. So the European guidelines suggest that amitriptyline is the drug of first choice, and that venlafaxine and mirtazapine, all 3 of these are antidepressant drugs. But they recognize, as you can see there with the statement from the guidelines, that the efficacy of these drugs is often limited by side effects. So they vary from the different drugs you have up there. Amitriptyline, for example, is more dryness, constipation, weight gain, perhaps sedation. Venlafaxine is more rapid heartbeat, sweatiness, weight gain, maybe insomnia. Mirtazapine is very sedating, weight gain also. And so you hear wait, and that's certainly an issue when we're dealing with headache, where at least with migraine we're seeing increasing evidence that the heavier you are, the more likely you are to have trouble with your headache. So you have to be, certainly in a setting where this is necessary to be introducing these types of medications. And when you do introduce them, perhaps get somebody to a better place and then taper them after 6 or 12 months of better control. Next slide. So that's it. We've gone through the basic features of tension-type headache, the fact that it's the most common headache in the population at large. By the way, it's not the most common headache to see a doctor. Migraine is still that. Migraine by far is the most common headache still to go in to see a doctor, even though this headache is the most common headache in the population. We've defined chronic and episodic tension-type headaches based on the numbers of days per month. We've talked about their treatments that are either non-drug or the medications that can be used when you get a tension-type headache, or the preventive medications that can be used if you have very frequent tension-type headache. So now that we've covered probably the basics of this over the course of about 15 minutes, I think it's time now to open it up for questions.
Thank you, Dr. Kaniecki. Our first question comes from Denise. She says her daughter has tension-type headaches, and after multiple tests, an outpatient rehab doctor did trigger point injections, which helped tremendously. She did physical therapy and acupuncture for months. Recently it spiked again, and he repeated the injections but would not use the steroid. 5 months had passed. They identified the muscles that were causing the problem, and she has many knots in her neck and shoulders. Direct work on the muscles usually increase her pain. What other treatment options would you recommend so that they can work on the muscles without increasing the pain?
Well, I think the trigger point injection option, which we did not discuss, there's just not enough information in terms of the scientific studies that have been done with this to put it as one of our headline treatments. But are they effective? Absolutely. So what's been determined is that there are areas of the muscles in patients. Now, I would say it's about half. Clinically, there are about half of patients who have a very, very significant muscular piece. And as you saw, there's not enough data to support either physical therapy or acupuncture. They might help, they might not. So that doesn't surprise me, that there was not a great response to those treatments. But the point of the trigger point injections is one that's very valuable, because what has been shown in patients, particularly that have chronic tension-type headache, and if this individual is having so much trouble, my guess is they fall into the chronic category, that there are areas of the muscle that clearly are much more active, and they can be settled down by these injections. And to date, there's been no great evidence to support the need for steroids in the injections. You can include them. Many of us do. I will do steroid including injections perhaps every 3 months. Now, you can't, if there is a lot of frontal or forehead involvement with these headaches, then that's a different story. You have to watch steroids that are placed in areas that are kind of cosmetically obvious, because occasionally there's a temporary little divot in the skin that can occur when one uses steroids in these subcutaneous injections. So you have to be cautious in areas that are kind of obvious to sight. But a lot of these are in the neck or the shoulders, where a small change in skin texture for a period of time, for a brief period of time, won't matter all that much. And inject them. And so that can be very helpful. And there are those that do them more frequently. Our particular policy is to try to restrict them to 3 months, because if they're not lasting 3 months in duration, then they're probably not worthwhile doing weekly or every 2 weeks. It means they're really not working very well if they're only lasting that short time. But if she got several months out of it, it would certainly be worth trying and retrying again. And without steroids in the injection, there probably would be very little to limit how frequently you could repeat that. Now, the other thing that can help very much in this setting is stretching. And we can look at 2 ways to do it. One is called a series of static stretches, where you just basically hold a position for a period of time. And then the other means is dynamic stretches or ballistic stretches, which tend to be more helpful. So where there's kind of a more vigorous movement, and that can be trained by the physical therapist. So static stretching sometimes helps, but I see that to be a little bit less effective than people who start to become more involved in rotational or ballistic kind of movement-related stretches where you kind of rotate or move the joint through a series of positions. So, for example, if you were going to stretch your neck out, you can do head tilts, your ear to your shoulder. You can tilt your ear to the left. You could tilt your ear to the right, and you could hold that position for a period of time towards your shoulder. Well, what we teach people to do is to kind of roll between them. So tilt your ear to your left shoulder and then roll the head forward all the way through towards, looking towards the floor and rolling it all the way back, and then temporarily holding it ear to the right shoulder. So there are different stretch techniques that can be very valuable. The trigger points, as mentioned, as you've already said. The heat, if you're going to do something through an acute stage, heat tends to be more effective than cold when it comes to these types of trigger point management, so local heat can be of value. And then finally, there are sometimes, if this is very, very difficult to control, what we call centrally acting muscle relaxants. One of the medications is called tizanidine. So the typical regular muscle relaxants that you think of with muscle strains or, pulling your back out, those don't seem to help this type of headache, but sometimes the centrally acting muscle relaxants, and again, probably the one most commonly used is called tizanidine, that can be helpful as well.
Thank you. We have a few people asking the same question. Can Botox be used for chronic tension headache?
It sure makes sense, doesn't it? It makes absolute perfect sense that it should work in tension-type headache. We talk about the muscles being involved. Turns out it doesn't work. At least in the clinical trials that have been done to date, it was not all that effective. It turned out it took a while for the benefits to be shown in chronic migraine. And it was not until that the studies were designed in a certain way and basically the episodic migraineurs were excluded. So it turned out that in migraine, the Botox or botulinum toxin only worked in the worst of the worst. And it was in the people that were milder, now it's not even approved by insurance companies, but that's kind of a moot point because in the patients that weren't as bad, it really didn't seem to work all that well. So it may be that we have to select that chronic tension-type headache population better and study it a little bit better and really look for those people that are not just 15 days a month, but the ones that are really struggling, the ones that are in their 20s, 25, 30 days of headache per month. It may be that subgroup, the worst of the worst, needs to be studied separately. But at this point in time, there is not enough evidence to say that it works in chronic tension-type headache, and therefore it usually doesn't get covered by insurance. At least here in our area in Pittsburgh, it does not. So you have to have that label of chronic migraine in order for it to get covered. Now, occasionally there is a condition called cervical dystonia that's present where it's the other term this goes by is torticollis. And there are patients who have basically primary muscle problems that just also happen to have the headache. So the headache's not the issue. It's a symptom of this muscle condition that causes significant tilting or turning of the head and neck. And most of you have you probably know what I'm talking about, where somebody's head is tilted to the side and they have a tremor, almost looks like a Parkinson's tremor sometimes. Well, that type of twisting motion in the head and neck is called torticollis or cervical dystonia. And botulinum toxin or Botox can be effective in that setting. And for those patients who have headache due to that, well, it can be real helpful. So that there are muscle conditions where headache is a symptom that benefits very well from Botox injections. So I think it's just going to be a matter of perhaps finding a better study population to work this into to get the information to support then scientifically and then to the insurance companies, because that's what they're going to be looking for. If you're going to want to cover this, you're going to want to make sure that it works. So in the worst of the worst, I think we need to study this a little bit better. But for now, it still would be considered off-label use in tension-type headache.
Thank you. Our next question comes from Kelly. I I've had chronic daily tension headaches for 34 years. My question is, what is the best way to stop using ibuprofen and acetaminophen daily?
Yeah, that's a question we get asked all the time. The TensionType headache preventive medication. So if you were a migraine sufferer, I could give you a list of medications that are 24 long that would help you, Kelly, and I could even offer you, in this case, Botox. We just got asked about that. So we have a whole list of things that have been shown to be effective in migraine, in preventing migraine. And we could talk about a whole list of natural things to do that have been shown to be effective in preventing migraine. So if you were a migraine patient, I could give you a list of things that say, okay, let's get you off the ibuprofen, get you off the aspirin, and get you started on one of these treatment or a number of these different treatment angles. In TensionType headache, as you saw, boy, our slides weren't very long, were they? I mean, the number of medications for chronic TensionType headache were 3. And I just told you that there really hasn't a whole lot of evidence for Botox, and so that the list of things that we can say, yeah, let's go with this, ends up being relatively short, which is quite frustrating to you. It's quite frustrating for us to not be able to provide better tools for the treatment of this. And partly that's due to the fact that one of the things we haven't talked about, as you see in my slides, is we didn't talk about what causes it. Well, the reason for that, we talked about that the muscles are involved. We didn't talk that the muscles caused it because we really don't know that. We really don't know what causes this. And the basic biology, what's going on in the brain, what's going on in the circuits that connect the nerves and the muscles to provoke these headaches, those steps remain a little bit unclear. So therefore, we don't have a whole lot of steps from a medication perspective and from a natural perspective that we can say, yes, this is something that you can do. So you've seen through the slides what things are available to you. And the other point to make about coming off these medications, first of all, if you've been on them a long, long time, there's no rush to come off. It's usually better to taper them. So over a month or 2 months, go ahead and take them down slowly so you don't have an active kind of rebound headache coming off of the medication. So that would be one thing, to come off slowly. Number 2, I think of all the natural things one can do to help themselves, it's a vigorous exercise program. And that's sometimes hard when you're having headaches. But the exercise in the 30 to 60 minute a day range, something aerobic. You don't want to do a whole lot of weights in the upper extremities when you're having neck and shoulder problems right up front. So you're talking about aerobic, and most importantly, incorporating in that a yoga type of program. So aerobic and yoga exercises that one would do daily, between 30 to 60 minutes. So I think that's incredibly valuable in helping this. So gradually taper what stuff you're on that you want to come off of. Again, a month or 2. During that period of time, begin an active exercise and yoga program and get yourself involved in that. By a month or 2, you start to see some dividends from that. Consider and talk with your doctor about the options that you see on here in terms of preventive medications. And then have something on hand to use, and let's say if you're on ibuprofen and you weren't taking naproxen, then you would do naproxen. But you would limit it strictly to 10 and maybe in a pinch 12 days a month. So go to a program where you're going to say, I'm going to ride out some of these headaches. I'm going to give the medication, the preventive medication, a chance. I'm going to give the natural things like exercise a chance. I think magnesium can be helpful in this, 500 milligrams a day. And this is not as much data in that as we have in migraine. But I think there's places for natural supplements as well. And if stress is a trigger, stress management techniques, as you saw listed on there, whether it's biofeedback or cognitive therapy. So trying to avail yourself of all the tools that are options for you to get better. And be patient. Once you stop, so in terms of the medication overuse effect or the rebound effect, once you stop the medication, some patients take 3 or 4 months for their brains to finally recover. So the analogy, again, I gave up earlier was to say, let's look at this as over-fertilizing your grass. Let's just look at that, over-fertilizing the plants or the grass. So if you decided, wow, I think I've been overdoing it here, and you stop the fertilizer after overdoing it for 10 years, it's not as if your grass is going to come back tomorrow. It's dead. It's burned out. And it's going to take a season to start to fill in and green up and get thicker. And so 3-4 months from the time you stop, you finally can say, okay, whatever impact occurred from over-treatment, from overusing the medications, has now dissipated, and I can see what I got. So if you have two battles to fight, and when you're in chronic tension-type headache, the battle of the headache itself and what that is doing in generating pain, and the battle of the medication overuse and what the rebound effect is doing in pain. So you got a couple of battles to wage. So give yourself some time and do that over a span of 3 or 4 months. Give yourself a nice horizon where you'd say, let's look at getting to goal over that period of time, and see how you work. That's the best way to do it.
Thank you. Our next question comes from David. Is there a best over-the-counter medication for tension headaches? And also, how often can one take over-the-counter medication in a 24-hour period?
Well, it's the 24-hour period question. It depends on the drug. So each drug has a different limit, and you basically, if you're looking at over-the-counter agents, they're all listed on the bottle. So how many is the maximum dose will all be listed. Now, the maximum dose of an over-the-counter remedy differs from the maximum dose of the same drug when delivered by prescription. So, you may see that, in fact, a prescription strength might be 4 times or even 5 times what you're allowed to do from an over-the-counter strength perspective. So the dosing varies, but it's based on the drug. So your best advice, how many doses per 24-hour period, just look on the bottle, because it'll vary from the different over-the-counter agents that are available. How many pills at a time and how many times a day will be dictated by the different drugs. The safely per month, again, we're trying to keep to 10 to 12 days a month. 10 days is ideal, 10 or under. And which one's the best? Well, they've not all been studied head-to-head in a very rigorous way. But what I can say is if you look at the information, simple acetaminophen is kind of first line. Aspirin in full doses, and you're talking, between 500 and 1,000 milligrams of aspirin. That seems to be a little more potent. The non-steroidals may be just a touch more potent than that, so ibuprofen or naproxen in full dose. And then finally, the combination agents that contain caffeine may be a little more potent than that. So if you had to pick one, then probably the combinations, because they have multiple things in them, and that's not surprising. In this case, two different medications and caffeine versus just one simple medication is going to be more effective. However, I think that you have to watch those a little bit more, because when you start using combination medications, ones that have aspirin and acetaminophen and caffeine, you have to be aware of the fact of toxicity, because they work in different organs when you're using a lot of these things. And I think, and particularly the caffeine-containing products, have a higher chance of giving you a medication overuse. I mean, you may not be able to get by with 10 or 12 days. Maybe it's closer to 8 days a month as a limit when you start using ones that have caffeine. So I think those caffeine-containing ones, talking to patients, doing this for over 20 years, those seem to be the most effective. But it also, I will tell you right now, they are also the drugs most likely to get people into trouble because they start overusing them. And just like any other caffeine situation, caffeine withdrawal itself causes headaches. So patients get used to taking these medications, and when the caffeine wears off the following day, they need to repeat it again. So be cautious with you're better off starting with the simple agents first, and if they work, great. But if not, then graduating to ones that are multiple medications with caffeine.
Our next question comes from Tom. Can you comment about Lyrica being used for headache prevention?
Lyrica is, for those unfamiliar with it, is a anti-seizure medication. It was originally designed for and is a cousin to Neurontin, and designed originally perhaps for seizures. But like Neurontin or gabapentin, Lyrica was found to be helpful in pain. And it has an indication for treatment of pain. Specifically, one of the indications is for fibromyalgia pain. So there is a subgroup of tension-type headache, and a subgroup of migraine, for that matter, who suffer from fibromyalgia. And for those who have fibromyalgia, they basically have pain in multiple joints and multiple muscle groups, and that can include the muscles and joints of the head and neck. So in that setting, you might say, basically, this somebody has fibromyalgia of the body and fibromyalgia of the head. And if that is the case, then Lyrica may be worth an option, may be worth a consideration. Typically in years past, we had been using gabapentin or Neurontin in that setting as well. So Lyrica is a branded medication that is more expensive than Neurontin or gabapentin, and in some places you have to get prior authorization. So as a treatment for headache, either migraine or TensionType headache, it typically is not covered. It would not be approved by the insurance in many situations because it is not a covered indication. But should the patient have headache as a symptom of fibromyalgia, then you might find an availability to it. That being said, you didn't see it on our list because there's not enough evidence, neither in migraine nor TensionType headache, to say that it's a very effective agent. So that's why I would suggest that outside the context of fibromyalgia, it would not be a choice of mine at all. In the context of somebody with fibromyalgia, it may be worth a consideration.
Thank you. Our next question comes from Chris. I'm familiar with amitriptyline, but not the second and third preventative medication you mentioned. What are the brand names of those other two antidepressants?
So I'll name the brand names of all of them, so we're going to bring that up. So amitriptyline is Elavil. That's been available for decades, basically. It's been around for a long, long time. The other two are relatively newer than the amitriptyline, but that doesn't take much because that's been around forever. So these have both been around for over 10 years. One, the venlafaxine is also known as Effexor, and probably now more commonly prescribed as Effexor XR. And the other one, mirtazapine, its brand name is Remeron. So both of them have been branded medications for, as I said, over a decade, but both are now available in generic as well. So the venlafaxine, otherwise known as Effexor, and Effexor XR, two versions, and the mirtazapine, otherwise known as Remeron.
Let's see here. Our next question is from Nancy. Can TensionType headaches accompany chronic daily migraine and chronic daily cluster variant? I started with TensionType in childhood and had my first migraine with aura at 13. I started with occasional cluster and cluster variations at age 30 when we lived in Colorado Springs, where the barometer often fluctuated and rained and snowed often, raining most afternoons of the summertime too. Is it fair to say I have not been without a head and face ache in 45 years? Am I dealing with chronic TensionType headache also?
Well, you may, and I kind of referred to this a little bit, and in terms of the Europeans versus the Americans and the way they counted the numbers of headache patients, the numbers of patients who had episodic TensionType headache, and I said that the Danes in Denmark, they looked at migraine people who had TensionType headache and said, these are migraine people and they're tension headache people, so they have both kinds of headaches. But here in the United States, over the years, we've been much more likely to kind of group these as single headaches. So we think of a headache as a spectrum, that migraine people, when we look at them, they will experience full-blown migraines. Some will get aura, visual lights or lines, and some won't. But even the ones, let's take the subgroup that gets aura. The ones that get aura, the neurological symptoms, the visual symptoms, will say, yeah, sometimes they get the aura without the headache. Sometimes they get them together. Sometimes the headache comes without the aura. So they have a variation of options when it comes to their headaches. And most migraine people, when you ask them, will say, I have milder headaches. They may call them sinus. They may call them tension. But there was a big study done in 2000. It was called the Spectrum Study, and migraine sufferers were taught in the trial to treat every headache they got with sumatriptan, with a migraine drug, every single headache. Whether they thought it was migraine, whether they thought it was sinus, whether they thought it was tension, they took sumatriptan for every headache. And it turns out that it worked the same on all headache types. So the lesson that we thought we learned from that was that migraine people get headaches that look like tension headache. They may get headaches that look like sinus headache, and that when you treat them, they actually respond like migraines. So migraine people get a menu of headaches, a menu of migraines, or in this case, a spectrum of migraines. So I think that's the majority of migraine folks who have this lower grade headache, and particularly one that may come daily to near daily. It appears that's just a variation of their migraine, a daily low grade, let's just use the word tension migraine for want of a better term. There are those, though, and I think that's of the people who have migraine, that daily to near daily headache as well, I think 90% plus will be it's migraine, just big and little. There are about 5 to 10%, however, that I truly believe have two different types of headache. They have a migraine headache and they have a tension type headache. The underlying headache doesn't seem to behave the same way. So the migraines come and go and they go up and down, and maybe they're 5 days a month, maybe they're 20 days a month, but the underlying headache doesn't seem to change whatsoever. It doesn't follow the same patterns. It doesn't get worse with the menstrual cycle. It doesn't. The fact that you get weather impact would make you much more likely to be migraine than tension type headache. So if the daily headache is impacted by the weather, as you mentioned, I don't know if that's the headache you're referring to, that you mentioned the weather changes you're exposed to, that if it is impacted by the weather, then I think it's going to be a little more likely to be migraine than it is tension type headache. But it's going to be hard to tease out. You've had the daily headache for a long, long period of time. There is another condition that sometimes dates back to childhood called new daily persistent headache, that is a flat line, basically a light switch. One day the switch went on and it just never went off. And then there are some of those patients that eventually end up developing migraines later in life that just happen to have a daily headache that never went away, for years or sometimes decades. So the origin of the daily headache in somebody who also has migraines, one possibility, again, is that it's migraine very frequently but low grade. Another is that there's a tension type headache pattern present. And the third is there's something else responsible for the everyday headache. This one condition called new daily persistent headache, or as I mentioned earlier, fibromyalgia, if that's present, causing a daily headache, or if somebody has depression, that's one of the most common symptoms of depression is daily headache. So there may be something else that's responsible, and when we see a divergence in the way the headaches behave, if the bad headaches don't seem to always cycle in sync with the daily headache, then we're considering some of those other options. So, and I don't know if you still live in Colorado Springs. There's not you have certainly dry periods of time for extended periods of time, as well as your periods through the late summer. So if there's a significant variation in the daily headache from one point of the season to another, then that you'll probably assign that more to a migraine quality. Otherwise, maybe get yourself some time over at the Broadmoor, maybe spend a little time over there, or take a hike through Seven Falls. And you got some beautiful land there in Colorado Springs, and get the activity level a little bit higher, and maybe the exercise will knock both headaches down.
Sounds good. Our next question comes from Eileen. Can you discuss mixed tension migraine headaches? For example, bilateral, not throbbing, moderate to severe, but nausea and perhaps vomiting.
So that's migraine. So as soon as you meet criteria for migraine, you no longer tension headache in that setting. So I'm glad you brought that up, because when we see people who have tension type headache and when they present to us in a clinical setting, the first thing we need to do is make sure they don't have something bad. So for example, if you've only had tension type headache that's daily for a month, let's just say that. You've never been a headache person before, you're 50 years old, you come into my office and you say, I have a new headache, it's been daily for the past month, and it looks just like a tension type headache. One of the criteria of tension type headache is that you've excluded other possibilities. So somebody going into a month of headache may have a condition known as temporal arteritis, or inflammation of their arteries of their scalp if they happen to be 50 or over. They might have a brain tumor. So the first step in analyzing anybody who looks like they have tension type headaches is to make sure that they don't have another condition. So the first step in any, when we go through the diagnostic criteria here, the first step is to make sure, you know what, there isn't anything I need to worry about. Now, if you've had headache, like a couple of people already online have said that they had headache for 30 or 40 years, well, the odds of that being a tumor are basically zero, right? But if you have headache for within a short period of time, let's say less than 6 months, new, progressive, even if it looks like a tension-type headache, we're always, cautious in thinking, is there something else we need to rule out? So that's a place perhaps where someone gets a scan. Once you've done that, then the next question to ask is this a tension headache variation of migraine? Since migraine, as I mentioned, is much more likely to be seen in the office. In fact, 9 out of 10 patients who come to see doctors for headaches end up having a version of migraine. So since migraine is so much more common in a doctor's office, it's not the most common headache in the population, as I mentioned, that's tension headache, but it's the most common headache in an office. And since it's so common to see migraine, and only 3% of the people we see in an office are tension headache patients, we need to make sure that it's not a version of migraine. So the point you're making of a kind of a mixed or an overlap, really it's probably better to use the term overlap. So migraine, 40% can be both sides of the head. So although we look at one-sided pain, unilateral, 40% can be bilateral, both sides of the head. Both can be, so both migraine and tension-type headache, migraine's more likely to be one-sided, but it doesn't have to be. Tension headache is more likely to be two-sided, but it doesn't have to be. Remember, on those criteria, you just needed 2 of the 4 pain features. So you could have tension-type headache that can be one-sided and more steady, and it maybe got worse a little bit with physical activity, but it was mild. So you could have some of the features that we saw on that list, but you don't have to have them all. So what you're looking for migraine specifically is this. Here's simply the 3 S's. It's a migraine, keeping migraine simple. Simple S. You're looking for severity, sensitivities, sickness. So severity of pain, that's one of the best distinguishers. Migraine gets severe. Tension headache, by definition, never is severe. So migraine at times should become severe. Second one, sickness. Migraine causes nausea. Tension headache does not cause nausea. Finally, thirdly, the migraine causes light and noise sensitivities many times. Tension headache does not cause both. It can cause one or the other. So if you're looking for 2 of those 3, the severity, the sickness, or the double sensitivities, and therefore if you have those, then you end up having migraine. And it just may be that it's a version that kind of overlaps a little bit in its appearance with tension-type headache.
Thank you. Our next question comes from Kelsey. I have chronic tension-type headaches and also get migraines at least once a week. What are your suggestions on medication that could be used to help lower the days?
So in terms of the medications we showed here, the people that have migraine, if you truly have migraine and tension-type headache, then amitriptyline and venlafaxine or the Effexor. So those 2 are drugs that have what we call kind of level 2 evidence in migraine and are 2 of the top 3 drugs to use in tension-type headache. So those would be the most effective agents to reduce both migraine and tension-type headache numbers. In terms of the natural approaches, as I mentioned earlier, exercise, an aerobic exercise program would probably be the best, most effective natural treatment recommendation we could make to reduce the numbers on both counts. And other than that, we didn't go much into this yet. So the other kind of the overall recommendations we make to everyone with headache, particularly frequent headache, is strict regulation of their lifestyle. So strictly regulating your sleep patterns, not napping, not sleeping in, trying to keep regular sleep schedules, your meal patterns, eating 4, 5, or 6 times a day, usually half meals or snacks, the exercise, which I mentioned, 30 to 60 minutes, hydration, somewhere between 40 to 60 ounces, and getting back to the question we had from Colorado Springs, that you probably in a drier climate need to be at least 60 ounces and perhaps 100 ounces a day of water. So adequate hydration. So regular sleep, regular meals, regular exercise, regular hydration, and then regular scheduling. It turns out if regular school attendance, regular work, seem to be very helpful in getting the migraine brain and the tension headache brain to a better place. It does better when it's pushed, when it's exercised, and I think that work exercising the brain, school exercising the brain on a regular scheduled basis can be valuable as well. So in terms of the drugs, as mentioned, probably the two with the best overlap information to cover both headache types would be amitriptyline and venlafaxine.
Thank you. Our next question comes from Scott. How do you correctly diagnose rebound headaches, and what do you do?
Well, the diagnosis is usually based on the combination of headache escalation and pain reliever escalation over time. And usually patients will also say when they're in this pattern that when they try other things, either nothing else works, or if it works, it only works for a short period of time. So that's where you find it. So you find it in people who have very frequent headache, so they're averaging 15, 20, 30 days a month, so it's over 15 days a month, and they're in a setting where they're over-treating with pain relievers, again, typically more than 15 days a month, and that the headaches and the pain reliever use has been documented to kind of escalate over time, either abruptly or gradually, and that other things you try don't seem to work all that well. So that's the setting, and then the management of this is direct, first of all. There is, in the setting of over-fertilizing the grass, going back to that analogy I drew, think about this. If you want to fix your lawn and you can lime it and manure it and water it and edge it and mow it and do everything right. So if your lawn guy comes in and does everything perfectly, but you're pouring fertilizer on it twice a day, once a day, even 3 times a week, nothing's going to work. What your lawn guy did is wasted money. It's wasted treatment. It's wasted chemicals. The fertilizer and everything else you're doing, is burning out the grass, so that everything that the lawn guy's trying to do to help is not going to work. So that's it. Basically, your lawn would be in an unfixable state had you continued to use the fertilizer. But the same thing with this medication overuse situation. Your brain's in an unfixable state as long as you continue to use these things. And just moving from one drug to another, switching from 20 days of ibuprofen a month to 20 days of acetaminophen a month, you're just rearranging the deck chairs on the Titanic, so to speak. You're not taking care of the problem. The ship is still sinking. So you got to make every effort to get your treatments to fewer than 10 days a month. And you got to make every effort to avoid the treatments that are even probably more difficult to use at that number. So no narcotics or opioids, no butalbitols or Fioricets, Furanols, Eschix, that class of drugs. These things are very aggressive in the way they create a medication overuse headache. No tramadols, no carosopradols, one of the muscle relaxants. These are all very aggressive in the way they feed tension headache and migraine. Get rid of all the bad stuff. Use the agents that we have listed on here as the more appropriate ones for tension-type headache. Limit those to 10 to 12 days a month, and then work on doing the lifestyle steps and then a good daily medication to help you out of this.
All right. Our next question is actually from Denise, and it's asking, is there any harm in trying a nerve block in an adolescent?
No, there doesn't appear to be, Denise. Nerve blocks or trigger point injections we have used in our adolescent population, so I do see adolescents at times and do use them at times. They tend to be maybe at times a little more skittish about injectable options, but no, there's no reluctance to use those at all.
All right. I see that that was about your last question. Do you have time for one more, or is?
Yeah, sure. Let's do another one. If you have another one, let's take care of it.
Yes, I do. It's from Tom, and he's saying that my doctor prescribed Butterbur for me last week. He has allergies and sinus headaches, along with lifelong tension headaches. What are your feelings on Butterbur? Are there any studies that support using it?
Well, there are studies that support the use of Butterbur in migraine. There is not a lot of information in tension-type headache or in the case of sinus headache or other types of headache. But Butterbur is an herbal remedy from the root of the plant called Petasites. So it's Butterbur root. And we typically had been recommending a specific brand that came from Germany that was a purified version of this. But over the past 6 months or so, it's been determined that that brand, that specific brand from the German preparation, may not be as pure, or at least they're not committing to the fact that they're manufacturing it in the same way they did before. So, although we may have been recommending certain types of brands of this in the past, I think right now we're getting past that. And the problem with Butterbur is that the root's medicinal, but the leaf and the stem can be toxic in higher quantities, perhaps, to the system. So purity of manufacturing is pretty important. And the guidelines, the restrictions on manufacturing of nutraceuticals like herbs are not as strict as what we have with pharmaceuticals. So, my prescriptions, my recommendations for Butterbur have gone down, since I can't necessarily vouch for the purity of any of these formulations at the present point in time, and I certainly don't want to create potential harm if it's possible. So it's been something we have been advising for some time. I have seen some patients benefit from it. I do have patients still taking it that have shown some benefit, but I would have to say, and I'd have to think about it more in depth, but I think they're almost all migraine sufferers.
Great. Well, we really appreciate you coming on and giving this presentation and also answering so many questions tonight.
Well, great. It's been my pleasure. It's been a lot of great questions, a lot of fun. I hope everybody got a chance to learn something this evening.